Excellent. And I am going to start by introducing, or letting them introduce ourselves, the people who are going to come and speak today. So going across my screen from left to right, James, do you want to introduce yourself?
Hi everyone, I'm a neonatal grid trainee. I'm ST8 and I'm currently working doing a clinical lecturer post at Chelsea. I applied for grid back in I think 2018 when it was face-to-face interviews, and have worked now at St George's, at Queen Charlotte's, and now at Chelsea, and yeah, really enjoying it, so definitely would recommend.
Thanks, James. Tash, you're next.
Hi everyone, I'm Tash. I'm ST7 and I applied for neonatal grid in 2019. Again, it was still face-to-face at the time, just before COVID. But I am currently on maternity leave after I had my first baby. So apologies if my answers are a bit rusty. But I do love the job and I think it's a great thing that you're all applying for. So if we can help you, we'd be glad to have you.
Brilliant, thank you, Tash. And Rachel?
Hi guys, I'm Rachel. I am also a neonatal grid trainee, shockingly. I'm an ST6 in 7 and I applied this year, so it was all virtual. I tried very hard, so I'm going to do my very best to share with you what you need to know to do well. You're all going to be great.
So you'll be pleased to know we're not going to put any of you on the spot today, but we are going to put some of our panel on the spot. We're going to make them answer some questions just so you get an idea of a model question. So the way we were going to run it is I'm going to just kind of give you a broad overview of what the interview is like, because last year it was quite interesting that some people didn't seem to know what to expect, and I don't know if I've only done it last year and this year, so I don't know if it's changed from previous, and particularly from going face to face to online. Then the panel are going to give you some of their top tips on prepping, I think, and how to deliver in an interview. And then we're going to give them, we've got 4 different sorts of questions that I'm sure you're all aware of. We've kind of prepped 4 questions for them to answer, each of them to answer. So they're going to give a kind of model answer. It may or may not be perfect. They're telling me it definitely won't be perfect. And I said that's only a good thing. And so and then we're going to have a think together about what's a positive indicator in an answer, and what should we be trying to avoid basically in an answer, or in a response to a question. And hopefully we can do that all together rather than you just listen to us talk. So as we go along, please do ask things, because this is a small enough room of people to make it participatory. Fine. Have I forgotten anything, any of the panel, before I just go into giving my quick spiel? No. Excellent. So you have been shortlisted for interview for today only. Congratulations. What are you going to expect? So we have a panel that have been had interviews before, but only one of them, only Rachel's done it online. And I mean, I had a grid interview, goodness, I would hate to tell you when it was now. In fact, I can't even remember the year it was. Maybe 2008, I think. And it was very different, I think, when it was face to face. I think the format of the interviews has been really pared back now, and is much less interactive than it used to be. That's not because it's online, it's just very, very standardized. So the interviews this year, to my knowledge, and as far as I know, they are online. And you will be given all the information that you need about connecting. I think all the normal rules apply when you're on an online interview. Be thoughtful about what you're wearing, probably not just for your top half. There was 2 or 3 candidates last year that had to get up and do something because their connection was wrong. And I just thought, gosh, it would have been pretty embarrassing if they'd been wearing their cycling shorts under their table, because now we would have seen it. Think about your background. My background, I've left it on because it's a really good example, is pretty chaotic. If I tidy up, it's probably all right because it's got some jolly hands that make me look like I'm a paediatrician. So I do use it for my child development meetings, but I just think it's worth thinking about what your background looks like. You want people to be looking at you and not what novels your rainbow bookshelf, for instance, or whose hands those might be, so, or who plays the bass guitar. So I think just the usual things apply, and I'm sorry if I'm telling you things you already know, but it is surprising how sometimes those things slip through, because I think people are anxious and they forget. So before your interview, make sure all your kit works. Make sure James arrived tonight and his mic didn't work and he had to come and go a bit. We will, of course, on the panel be totally accommodating of that, and it's not a problem if that happens to you, but it just doesn't help you feel like you're entering with confidence and now you're feeling a bit like, oh, I've made myself look like an idiot. You haven't. If those things happen to you, if you have a technical hitch, there is no agenda from the panel. It just happens to everybody. Somebody last year, I think, had a power cut, like their whole street went down and their power went out, including their Wi-Fi. And it was just on and off. And we had to reschedule them for the later of the day. And I just felt bad for them, not for us, because those things happen and it's really fine for those things to happen. So don't think that you're being judged on your ability to set up an IT system. You're not. I think those are the main things about just being there and doing online interviews. Make sure your mic, people can hear you on your mic. And if you need to, get onto Zoom and record yourself on Zoom and then listen to it back. You will be expected to have your camera on. I can't think of anyone that had their camera off last year. So do make sure you're set up. Some people go to their place of work or a place that's not their home to do it. And I can understand that. It depends, whether you've got 2-year-old twins or anything else going on in the background. So, I think just prep in a way that makes you feel confident. A little thing that I do, and you might think this is mad, but when I go for an interview, I put on an outfit that I think the person who's going to get that job wears. I go in feeling like that person. I know that sounds mad. So when I did a Wellcome Trust fellowship, I bought a suit that I thought people with PhDs wore. And I know that sounds really stupid, but I just thought I need to be that person. I need to be the person that they're trying to appoint. And that is absolutely true. We need to see behind your eyes. We need to see who you are. And it's all right to give a bit of yourself so that we can see who you are. But also you need to feel like you are that person. So I sometimes train people for consultant interviews, which is the next step up. And I say to them, you've got to go in there believing you are their colleague and you can be their colleague. Because if you feel like a fraud, we will see it. So prep yourself. All of you are more than capable of being grid interviews. The last person I prepped for a consultant interview, I said, could you do my job? She was like, yeah. I was like, yeah, you can. But she saw before that was a little bit hesitant in the way she answered things. And I think it's true. She was just like, when I asked her, she was like, yeah, of course I can do your job. That's why I'm applying for it. And I was like, well, it wasn't my job she was applying for. I'm glad to say I've still got my job. But so, yeah, it is about your mindset, I think. Go in thinking, how do grid trainees behave? How do they talk? You'll meet some today. You'll have met some in your training. How do I be that person in this interview? Because we are appointing you to be a grid trainee, and you need to present yourself as a grid trainee. And I think the other thing to mention, and I don't say this to be intimidating, but ultimately we're looking for people that can be consultant neonatologists. And so while we do not expect you to have a level of knowledge above your level of training, we do expect you to have a kind of overview of service. So if you haven't been to the capacity meeting where we move beds around for 20 minutes and say who's in what hospital, how do we get them in, how do we send such and such out, go to that meeting, because it might come up in one of your questions. And that sort of knowledge over and above how to clinically care for a baby, you do see it in the answers. We are kind of looking for it. We're looking for quite a holistic person, if you like, somebody who understands the job of a neonatal consultant and what we do every day. And actually, what we don't do a lot of is clinical care. I know that sounds a bit mad because that's what you're being trained to do, but actually it's about so much more. Only one of your questions will be around clinical care, and there'll be 4 questions. So just bear that in mind. Any questions about that? No. honestly, stick your hands up if there's anything that you want me to clarify on the way. So on the day, you will, I don't know what IT instructions you're given, I'm afraid, but you will eventually pop up, and on a screen, you will have 4 panel members, and there may be a disembodied voice. Last year, there was a disembodied voice that says, you may start, or you have 5 minutes to go. And we tried to ask them, we pleaded with them to not have the disembodied voice because it's really off-putting, but they just said, no, those are the rules. So also it's worth knowing that the rules are not made up by the neonatal CSAC. Maybe this is obvious to you. It wasn't obvious to me last year. The rules are made up at HEE and RCPCH level, and we just do what we're told. Okay, so we don't get to influence the process. The process is, you know, I will be given the interview questions on the day and I will deliver them according to what I'm told to do. So the process should be the same. And Rachel gave this top tip when I chatted to her earlier in the week. Go and speak to your PEM colleagues. You're this, you're that. The people who are doing grid interviews in other specialties 3 days before you, or 4 days before you, or a week before you, because they're all doing basically the same format. It's really standardized now. It's kind of tedious, it's so standardized, really. There's opportunities in that, I think, but there's also sort of, you'll see when I ask the guys to give an answer, that there's some challenges in it as well. So do pilfer information from people, talk to people widely and find out what is happening this year, because whatever's happening this year is going to be happening to you as well, because we don't get to influence that. We won't get to change it on the day. There'll be 4 panel members in a row in your screen, or somehow arranged on your screen. On my screen, they were in a row, and we will have 1 question each. We will introduce ourselves individually, say who we are, where we work, and then it's a little alumni of UCLH. And we would welcome babies in interviews, but if it's going to put you off your, please, you know, maybe ask your mum to come. We will ask you 1 question. So there will be a chair, and there'll be there's 2 panels running at any one time. There's 8 of us in total. You will have 4 people pop up. There will be a chair. The chair will introduce, and then we will introduce ourselves, and then I think you introduce yourself. I can't remember. And then we will go straight into the first question. We will give you 1 question each. Katie.
So sorry, do you only meet one of the 2 panels, or do you go between them?
No,
okay.
We have a list of, we have two lists of people, and I'm on 1 panel and the other group's on another panel, and we don't swap. Occasionally, if we know people, we might flip them over so that you get a panel of that you don't know, if you like. But we are very careful about, if we do know you, we're very, very careful about not bringing that past knowledge to the interview. So I would reassure you, if that, sometimes it's a bit weird doing an interview in front of somebody you do know. Sometimes it's easier doing it in front of somebody you don't. I think I was on your panel, wasn't I, Rachel? She's still smiling. And it was a surprise. I didn't even know you, Rachel, had applied. She just popped up. I was like, oh, hello.
No, it was really nice actually, because I didn't know you were going to be there, but when I was talking, I was looking at you because I know you're really nice and really kind, and you know me well, and I knew you would have to take the information that I was giving you on the day, but I knew in your heart you'd be like, come on,
sending you positive vibes. I'm hoping I'm sending everyone positive vibes. I really am. Yeah, so you'll get 1 question each. She's 25 minutes in the interview last year anyway, and I think it's going to be the same this year, as far as I know. Disclaimer if I'm wrong, but you will get a question given to you. It often has sort of 2 or 3 bits to it. Please do feel free for askers to repeat that question back. And then you will get between 5 or 6 minutes to give your answer. So don't, you know, the old school was, there's baby meconium aspiration, I'd say a bit, and as the candidate, they'd say a bit more, oh, right, and what would you do now? That doesn't happen anymore, because we've got a stem that we give you, and we're not allowed to give you any more. If you run out of steam 2 or 3 minutes in, we will stop, and then we will say, is there anything else you want to add? We won't prompt you, we won't say, do you want to expand on that? Or sometimes if we don't feel that you've heard the second part of the question, we might say, I'm just going to repeat the second part of the question again, just in case you didn't hear it, to give you an opportunity, because I think it's quite hard when you've got a kind of 2-level question to answer. And yeah, and then you've got 5 or 6 minutes to talk. And if you get to 5 minutes and you're still talking and you're getting towards the 6 minutes, we would usually say you're running out of time, or something gentle around, okay, we're going to move on to the next question now, because we really don't want you to take 15 minutes on one question and not get to another one. And that's because you get a score for each question. So each of the 4 questions gets scored out of 5, and you get a total of 20 points out of 20 points. Leah, you've got a question. My partner's just come in, so sorry about the noise in the background.
Thank you. I just wanted to ask, when you ask the question, do we have like a couple of minutes or seconds to form an answer or take notes or like anything like that?
You can take as long as you want. I would really encourage you to do that. I would really encourage you to say, thank you. I'm just gonna take a minute. Feel free to scribble. As far as I know, feel free to scribble. I think you can't look to be reading off notes, but I think it's all right to order your thoughts and then start. And yeah, that's absolutely fine. In fact, it's one of my top tips is really to do that.
You're allowed to have blank paper, and we were encouraged to, especially on the clinical scenario when there's often quite a lot of information, to make a couple of notes when you do that. So that's fine.
I think you've nicked my top tip, which is pause, think, take a deep breath, take as long as you need, structure your answer, and then deliver it. And it is a bit weird then where you've got 4 consultants just staring at you on a screen, but it is okay to just like trip over your words and say, actually, I'm just going to start that sentence again, like you're having a normal conversation with somebody. It's really fine to do that. And, you know, yeah, don't worry about that sort of thing. There's a noise in the background. Just stop, say, I'm going to stop, wait for my dog to stop barking. Yeah. Any questions about just the format for it? Then at the end, you get kicked out. If you get to the end, and you've got, maybe you've done 4 minutes on each question and you've got 5 minutes left, we will say, is there anything you'd like to add to any of the previous questions? That's what we did last year anyway. And I think that's because you know, you've had the 4 questions. We can repeat them again for you if you want us to. But often people have just run out of steam, and then afterwards they thought, oh, I didn't mention breastfeeding or talking to the parent or calling cats. You know, so it's absolutely fine to go back, because we only score you. Then you pop off, and then we've got 5 minutes to score you. And then we try to write helpful comments. So we give a score and we try to write, and we've got very clear positive and negative indicators for each of the questions to try and standardize it. Hang on a minute. Dave, do you mind closing the doors? Thanks. Yeah, any questions about the process? BJ.
Do we have all 4 members of a panel together? Or okay, not one after the other.
And we all score you separately. Yeah. There is some discussion around those scores in case there's any outliers, in case somebody missed a point. So it's not, you know, if somebody has a little petty mal and misses that you said 2 or 3 important things, we do kind of have a little bit of a discussion to check that hasn't happened, to make sure it's fair again. Katie?
Sorry, admin. Do you get a final mark out of 20 or out of 80?
20.
No, 80.
80.
Because you get 20.
Why did you know that, Rachel? What happened to you?
I got 79 out of 80.
Where was that last mark?
She actually got 74 to start with.
Yes, Callie.
75, and I failed to give her a score because the system that we use is awful. It's absolutely horrendous, the IT system that we score on, and it just didn't enter my score. And it came back a lot of time afterwards saying, oh, somebody failed to score Rachel. And I was like, oh my God, it was me.
And I got an email in the middle of a night shift when I'd just woken up in the day saying, you're having been shortlisted for the job I wanted, saying your grid application score has been amended. And I'm like, luckily it had gone up, not down. So it was okay.
So anyway, very transparent. Somebody had their hand up then and then they put it down. Or they... Purav.
Yeah, but I think the answer, I think you guys just answered the question. I was just going to ask, are they then average the scores, or are they then cumulative added together each section? Yeah, so yeah, thanks just for clearing that up.
Yeah. I can't remember the exact rules about what we do with tied scores. One important thing is we do not see, none of us on the interview panel, to my knowledge, certainly I didn't, have seen your application form. So you are not being appointed at interview on anything to do with your application form. It is only being used to shortlist you. If you do a beautiful application form and you flunk the interview, you flunk the interview. The only time I think they use the application form is if you're head to head, if you've got the same score as somebody and you're cusping, one person gets in and one person doesn't, then I think they go back to your application score. But it is all about the interview once you've got the interview. Jess, I think you put your hand up.
Yeah, it was just when you said about there being the 4 questions and that we wouldn't be asked to kind of elaborate on any of the points. Is it very much sort of you go in and there are four questions and there's no vague small talk or chat? It's just very business.
The beginning is small talk and chat. Hi, how are you? You know, trying to put you at ease, and then it is the 4 questions, and there is no chat. We're not allowed to chat because it is thought to be unfair. So if you say something, I can't say, do you want to expand on that point? I'm just not allowed to. The only thing I can do is repeat part of the question if I really feel that you've not heard it and not responded to it at all. Mm-hmm. So yeah, it's a bit weird. I guess it's in the interest of fairness. Mm. And it is probably fair because it takes away unconscious bias and stuff to a degree, I think, which is important. But yeah, it is a bit weird.
Thank you.
It doesn't help us put you at ease. And I suppose we're probably not supposed to kind of be too enthusiastic in the way we look at you, or, you know, we try to be nice in our body language on Zoom, which is insane. Right. Any questions before I hand over to the panel for their little top tips? Who would like to top tip first then? Can't remember what order we said now. Oh, there's 4 different sorts of questions. Shall I just say what they are? You probably all know this, but we're going to use these 4 headings today when we do examples. Career motivation and past achievements, which is basically an introduction question or a CV. Who are you? Question. Academic understanding and ability. It is not usually, in my experience, and I hope this year they don't change this, but they're not what I would call research. As a researcher, as an academic, they're not really academic, they're not research questions. There is no unseen, read this paper and tell us what you think of it, no critical appraisal skills, nothing like that anymore. Or certainly there wasn't last year. We'll talk about what might come up in that group, but think about it as data, quality care, service, quality delivery, benchmarking, that kind of stuff. The third one is ability in clinical situations and reasoning. And we'll talk about that. And the final one is exploring multidisciplinary team working and learning skills under a broad governance, I would say, the sort of topics that you put under governance. So those are the 4 areas, and then we're going to talk about those each in turn. So were you going to go first, Rachel? Sorry, I just thought I'd say that before.
Oh, I thought Natasha was going to go first, but I can do if you want.
Go, Tash.
Hello again. Sorry about the baby. I've literally asked my mum specifically to come over to look after her, and then she just dashed out for a minute. My top tips, I will keep them to 4 of them because I think Rachel and James both have plenty of good ones that overlap with me. But I would definitely say this is your opportunity to really show your passion and what makes you unique. Like, why do they want you over the next person, the person in the next screen bubble head next to you in this webinar? Why are you special? And I think that's really why you need to think about that a lot before you go into the interview. And I also think with each question, you almost want to think about what are they trying to get out of you? And I'm hoping that by the end of this webinar, you'll have more of an idea of that, because you'll say to yourself, okay, this is that type of question. what they're trying to get out of me is X, Y, and Z. And if you can give them those things, then there's no reason why they can't employ you, if that makes sense. I'm a big fan, as Callie has said, of preparing yourself in your environment. She's gone through all of those things, but I'd also like to echo her structured approach idea. And there are lots of ways to structure an answer, and there's no better or right or wrong, but you do need a structure, because I think waffle is the death of many people in interview, because you just tend to waffle on and you don't get your point across in time. I favour case-based answers, which I will hopefully demonstrate in not a terrible way when I answer Callie's question in a minute. And then also show your working, because they want to know, how have you got to the point that you're telling them about it? They want to think, okay, how is this candidate thinking through the answer that they're giving? Is this somebody who thinks logically? Is this somebody that I can trust to work on my unit and eventually become my colleague one day? And the only way they're going to know that is if you show you're working. And pause. The big pause before answering is really important. It's only human nature to fill that gap, to fill that silence. And actually, you only do yourself a disservice if you rush in and start waffling. Those are my top tips. And I'll hand over to one of the others.
Holding a silence is a life skill. I live with a psychiatrist. They are very good at holding a silence, and practice it for this interview, because it's really useful for your communication with families as well. If you always fill the gap for families, they won't tell you anything. So yeah, don't fill the gap. Leah, you've got a question.
Yes, thank you. Tash said to show your thinking process. So are you allowed to say, for example, I will do this and this and this because that's the case, for example, or like, are you allowed to do that, and to what extent, if it makes sense? Like, we're not teaching you stuff because you already know it, but I want you to know that I know it.
I think you need to
don't
go on, Tash.
Sorry.
You answer. No, you answer.
I was going to say, don't overdo it. Don't say things that you think are, common sense or common knowledge. But I think it's important to establish why you're doing the things you're doing, if that makes sense. So you could say, this is particularly true of the clinical scenario. It's less true in the other ones, I suppose, although it's still hold up in the data question, I would argue. But you could say, I want to make sure that they've given this woman antenatal steroids, because I know that leads to improved survival rates and better neurodisability outcomes. That is all you need to say. It takes 2 seconds, but that shows you're working. Because you could be somebody who's not neonatal interested, but know that on the protocol, okay, I have to give steroids, but that doesn't differentiate between somebody who just says that because they know that's a tick box, and somebody who's actually thought about it and knows the outcomes. Does that make sense?
Thank you. James, do you want to go next?
Yeah. So I'm sure that some of these tips are going to be sort of, there's some overlap, because there's some things that are just really crucial. I think one of the things I thought was really worth highlighting was the importance of doing practice interviews, and really just doing as many practice interviews as possible with as many different people as possible. And partly that's just to get rid of some of the sort of nerves. Partly it's just to feel a bit more comfortable, but partly it's also just so you can have those car crashes that will happen and get them out your system before the day. So I had a particularly awful practice interview with one of my supervisors, where in response to a question about management of extreme prematurity and the ethical issues, for some reason within the 5 minutes, I managed to get onto abortion, and spent about 3 or 4 minutes talking about abortion and the ethics of abortion. And he just sat there at the end and he was like, literally, what are you doing? What were you saying? Like, it's not relevant. It's not your area of expertise. You know nothing about the subject, pretty much. But it is so easy, particularly like people said, if you don't take that moment just to think about what you're saying, you just start talking, and then you keep talking, and then you keep talking, and then you end up somewhere you really don't want to be, and just continue digging that hole until you're gone. So I would definitely get the practice interviews in. Have the pause before speaking, not just so you can avoid making a complete idiot of yourself, but also like it gives you a chance, because this isn't just answering a question. Like this is your interview. You're trying to sell yourself, and there's that awful thing that politicians do where they don't answer the question, they just say what they want to say. And that isn't what you need to do here, because you've been asked the question, they do want to know the answer to the question. But you also do want to take this opportunity to put yourself across. So, if I'm on a ward round and a medical student comes and asks me, why did I do neonatology? I'm probably going to start by talking about how geriatrics smells and general pediatrics is just treating viruses all day. And then talk a bit about, how interesting I find neonatology as a subject. But that's, that's the answer that is useful about, if that makes sense. That is why a large part of the reason why I do neonatology, but it's not really telling anybody why I'm good at doing neonatology, which actually is what I want to get across in the interview. So that's when you need to think a little bit about what you're trying to say as well. So that's why, I think taking that little pause, thinking what you want to say and trying to get those key points in. Then the other things, just these aren't so much tips, but these are sort of things I thought might be helpful. I think, everyone gets quite worried before the interview, but actually I think there are some reasons it's really positive and really quite a useful thing to prepare for, and I in some ways enjoyed it. I think the first thing is that actually this is something that's going to come in really useful in the future. And that's firstly the stuff that you're researching, the stuff that you're sort of revising and covering before the interview, that's the same stuff that's going to come up in START assessments in the future, which I've just done. It's the same stuff that's going to come up in consultant interviews in the future. So in a lot of ways, this is just the first time you're sort of doing this, the first go at preparing all this, and all the sort of time and effort you put in now is going to be, it's going to be useful in the future, if that makes sense. And the other thing is that actually, and I think Callie, has showed this really well as an interviewer. Like, it's actually quite nice, like, to have 20 minutes to talk about neonatology, which is a topic we're all quite passionate about, and that's why we're all here. And having 4 consultants listening to what you're saying, and again, I think Callie's shown that, like, they really care, and they really want to know what you're saying, and they want to know who you are, and they want to see behind your eyes, because they want to know your opinions. They're interested in what you bring to the table, and what you're going to say, and will be really paying attention, regardless of how blank the Zoom face is. But it is in a lot of ways a great opportunity to be listened to, and to talk about neonatology and to get feedback on it. And actually, I think the preparation and the anticipation was much worse than actually being in the interview. And being there and starting talking to people was actually, nowhere near as bad as the waiting for it. So those would be my tips and thoughts.
Thanks, James. That's really helpful. And that is absolutely true. And I should have said that. We are really interested in what you're saying. We all interview because you are our future colleagues. You're like, we're all very enthusiastic about the generation of neonatologists that's going to come behind us. And although it's hard to portray that in the interview, we are rooting for you, and we are looking for positive indicators. We're not looking to drag your numbers down. We are looking to push your numbers up always. So give us any opportunity to do that, we will do it. So we are on your side, even though it might not feel like it when you're in an interview. Yeah. Great. On to Rachel, who was the queen of being organised, and weren't you?
Yes, this is true. So
we're going to talk about prep, Rachel.
I am going to talk about preparation. I am a big prepper. So as you've discovered, I did really well. And the way that I did really well is absolutely reproducible. So I'm going to tell you how I did it. I was not asked any question I hadn't prepared more or less word for word. So every question I had was not a surprise in any way. The way I did that was, number one, by asking every single grid trainee, current or past, that I could possibly find everything they could remember about their interview. And I wrote down what they said. So that was job one. Job two, I did a lot of practice interviews. So I did practice with consultants, and especially consultants that you're afraid of. So don't just pick ones that are your mates, because you do need to be a little bit nervous, okay? And that does make a big difference. And I think you're more likely to get the harsh words that you may need to really pimp your game. The second thing I did was I had a interview practice buddy. So this was somebody else applying for grid, not neonates. Do not practice with someone who is in direct competition with you, my friends. This was someone applying for PEM, okay? That is because 3 out of your 4 questions are not specialty specific. It doesn't matter. And even if there is a specialty specific one, there's lots of overlap. So people applying for PEM, people applying for PICU, whatever you can find, because most of it is relevant. And 2 or 3 times a week, we practiced on Zoom. So we would say, okay, Monday, we're going to do questions about governance. And we would just prepare in advance generally, and then we would hit each other with questions. We would time it, and we would actively listen to each other. And then we would give constructive feedback. And it is a very good 2-way learning process. It also means that you're really good at talking, because you kind of have to get over that hurdle of like, I know what's in my head, but I need to say the words. And we did that a lot. I mean, I did hours and hours of practice with someone who was also quite competent, and our level really increased over time. She did very well as well. She was top of the year in PEM. So it does really pay off. So that's my key things on practicing. The other things I would say when you're giving your answers is when you make a point, like I'm great at neonates. Yeah, great, fine. But can you evidence it? So everything you say, you need to evidence. Think of it like referencing. I can intubate preterm neonates. Okay, great, evidence. Would be my main thing for when you're selling yourself, because you could be absolutely full of shit. Okay, if you can say anything you want, but you need to evidence it. The next thing I would say is be honest. Do not lie, do not exaggerate, because you will catch yourself out and you will forget. You cannot remember if you're bullshitting. Just tell the truth. When you're giving examples, so clinical examples, so tell me about a time you had a difficult communication, tell me about a time that you had a challenge with a colleague, try and make your examples the same for different things. So you're only going to get asked one question. So for example, my acute deteriorating patient, my leadership, my teamwork, my multidisciplinary teamwork was all the same example, right? So you only have to remember one, because you haven't got space for a different example for everything. And the last thing I would say for the question about why do you want to do this, is this process called like the 10 whys. Okay, I want to do neonates. Why? Because I like babies. Why? Because they get better. Why? Because the physiology is really good. Why? So think really honestly with yourself as far as you can down the whys. And then you're doing what Natasha was talking about and what Leah asked about, which is really evidencing and showing you're working. So those are the things that I did, and I did them hard, and it was very successful. And my colleague that I was practicing with did exactly the same thing, and she also did really well. So you can do it.
Just need loads of hours in your day.
Or be efficient.
Yeah, totally. That evidencing thing is really important. I hope that comes out in the next bit, because if you say you've been asked to prepare for a preterm birth that you think is going to happen in the next 20 minutes. If you say, when I'm in this situation, these are the things that I do. And you say it in a way that they are the things that you do, because they're honest, I can tell. And I'm like, yes, you do. Yes, you do that. If you say, I would go to such that, if you start to be a bit formulaic, anyone can learn how to respond to a drug error or a this or a that. I do a lot of interviewing for normal posts at our trust. So I do an awful lot of, SHOs and registrar interviews. And it is very easy to learn an answer by rote. And I cannot tell if that's really what you would do or not. It's amazing. And so actually I'm constantly looking for, would you? Do you? Because sometimes it's such a kind of perfect answer. It feels like you don't really know if they've just learnt it from a book. So just, give a bit of yourself. That's what I mean, give a bit of yourself. When this has happened to me, I didn't know what to do, and so I spoke to my consultant, and this is what they said. Just give an example that shows you've been there and you've done it, and that really helps us. It really helps us, be sure that you are the person that you're telling us you are. Leah, you've got a question.
Yeah, thank you. I think thanks, Rachel. That was very useful. I'm tempted to ask if there's a pool of questions, just because she kind of sold it.
Here she's back.
Sorry, had to have a wee. What was the question?
Is there a pool of questions?
There's a pool of questions that we can have a look at.
So not an official one, no, but there are various people that you could ask who might kindly tell you what they had last year. And feel free to get in contact with them if you want to.
Very diplomatic answer, Rachel, thank you.
There's always the joke that there's only about 4 diagnoses in neonates. So like,
There's only 4 drugs, that's
yeah,
for sure.
Like there's very limited.
And dopamine is not one of them, people. Okay. Yeah, that's true. I really liked your example of know what. If somebody's going to ask you about conflict, know what you're going to say. If you're going to say, tell us about conflict with a colleague, that I don't think the questions are formulated exactly like that, but you need to have an example ready. And so if that's an example, for instance, if it is something about conflict, have the example ready that you know that you're going to talk about, and please, please, please don't be right. And then I told them exactly how I was right and they were wrong. Look, that was great, because that actually doesn't really tell me anything about you. What I really want to hear is, I could really understand their perspective, but I wasn't sure that they understood mine. We discussed it, and ultimately we came to some middle ground, or we agreed to disagree is fine, but suggesting that ending with proving your rightness is sort of doesn't really give a depth of maturity to situations that we need to see. And I know that it's amazing how often that happens, because people basically, not because people believe they're right all the time, but because they think that's what the panel wants to hear. And it's not what we want.
I also think it makes you not very likable. Like ultimately the people you want to work with are people who can admit their faults, learn from their mistakes. Yeah. And if you just come across as I'm always right and I just bend the will of everyone around me to be what I think, you know, that's not a positive thing.
You can demonstrate reflective practice.
And it's really important to do that, because that is who you want to sit next to for the rest of, for the rest of your career. So yeah, absolutely. Don't be frightened of being flawed. It's fine to be flawed. Reflect. What did you change? One of the best consultant interview answers I ever heard was somebody who just had difficulties with their communication style that other people thought was a bit full on, a bit I don't know what the word is for it, and it got fed back to them, and they really talked about how they reflected on it and how they changed their behavior in response, because they were just a bit unaware that they had quite a direct communication style that sometimes was a bit intimidating for people who were more juniors than them, and they just didn't realize that kind of hierarchical kind of thing that happens when you become a consultant. So be honest, it's fine. Be human. Right, any other questions for these guys, or should we going to go and do some test questions? Okay, I believe Tash is on the spot first.
Yeah, I'm ready. I've passed my baby away.
I'm going to give we're going to do one question for each of the 4 areas. Tash is going to go first. We're going to start with the whatever the intro-y all about me question that I think of it as, but as I understand it, that isn't always the first question you're asked. So logically it should be the first question you're asked, but I understand it's not always the first, and I don't know if anyone else has had feedback from other panels on that. So are you ready, Tash?
Yes.
Thanks for coming today, Tash. I'm going to ask you
for having me,
and give you 5 or 6 minutes to give me an answer. Can you tell me what has driven you to be a neonatologist? What qualities you think a neonatologist needs to have, and how you fit those qualities?
Thank you. I think that's a really important question to start off with. I think there are 3 major things that come to my mind when I'm considering what makes a good neonatologist and how I'm particularly suited to the career and how it's motivated me to become that neonatologist. And in particular, I think it's a subspecialty that really requires composure under a lot of pressure. And that's not always clinical. It can also be the pressure of beds, for example, as well. I think it also requires sophisticated communication skills and a really deep compassion for the babies and the families that we look after as well. And whilst I've enjoyed many aspects of various bits of my pediatric career, for example, I loved the acuteness of A&E, it just didn't quite have the same connection of all of those three things that I feel are really important to me in a long-term career that neonates has for me. So I think a particular case comes to mind as well when I'm thinking about this. During a tertiary placement that I had, it really cemented my feelings towards neonatology when I was part of this case where a baby was born with multiple congenital anomalies and then had a postnatal diagnosis of trisomy 18. I was part of the initial resuscitation team. It was really difficult. And it really required me as the registrar on at that time to have some strong team working with my nursing colleagues, but also my junior colleagues and liaising with my consultant to make sure that the baby was stabilized from particularly the airway point of view. And then unfortunately for this baby, once we were on the unit, there was quite a disagreement with the family as to particularly redirection of care once it became clear that the baby wasn't going to survive. And I was able to be part of those conversations with the family and involve other teams like the palliative care team and the chaplaincy service. And eventually we were able to get this baby and this family to a place where they could make the decision, the very sad decision that was in her best interest to redirect care. And I just really loved that the incredible levels of compassion that were required in the subspecialty to see the amount of care and sensitivity that the whole team had when they were trying to support this family at the point of the baby's death, but even after that, surrounding, what we do with the baby's body after death, memory making, it just was so incredibly moving. And I think I've really demonstrated the abilities that I've just described to perform well under pressure in lots of other resuscitations, but also I've worked in low resource settings where the pressures are different, but just as intense. I worked as a global links mentor with the Royal College in Myanmar for 6 months. And whilst I was performing an audit as part of a QIP, I had to intervene on a rapidly deteriorating child with a tension pneumothorax. And my role in that as a global links mentor was also required developed communication skills. I had to bridge the gaps in culture, and I don't speak Burmese, and being able to talk to the local team whose English wasn't necessarily that good was really important to be able to affect change there. And one of my driving reasons for even taking time out of training to go to Myanmar was compassion for the wider world and also the communities that reflect where my family is from as well. So I guess ultimately I'm motivated by my goal to become a tertiary neonatal consultant who can provide excellent clinical care, but also provide the compassion and the communication skills that are required to really take care of the baby from their journey from the beginning all the way through to hopefully getting them out of the unit, whether that's just seeing them in clinic at 2 years old or whether that's giving them a dignified death, if that's what ends up happening for them. I really try and keep up to date with developments in neonatal care. I've attended BAPM and Neonatal Society meetings. I read journals as much as I can between shifts. And I really want to be a consultant who can talk and empathize with the parents and guide them through one of the most important, but also often most difficult parts of their lives. And it's really, I think, at the very core of it, the humanity of the job, connecting with the people, connecting with the families and the team that make it worthwhile to me.
Thank you. Literally, that's what I'll say. Thank you, Tash. I'm going to hand you on to my colleague, and maybe that feels a bit weird. So brilliant. Did anyone time that? Yes. Thanks, Eva.
I completely forgot. I was supposed to be timing myself and I didn't. Sorry.
I don't know what your top tips are on whether you time yourselves or not. Actually, some people it would.
I would.
You're not. Yeah. Okay. You were 4 minutes.
I did in my start interview as well.
4 minutes.
4 minutes and
20 seconds.
Not too bad.
So what do people think about Tash's answer? What do you think about her response?
Be brutal. I won't cry.
She signed up for this. Katie, go on, kick us off.
Obviously beautiful. It felt really long, like to just be talking for that long. Yeah. And like, it feels really weird to like talk about a thing and close the thing and then start another thing and talk. And yeah.
Ray has just put something about being terrified. I'm scared 5 minutes is long. Kind of is, isn't it? I'm quite immune to it now because I don't, I'm just used to it. But yeah, it is quite a long time.
It goes fast when you're talking though. It doesn't go fast.
I think traditionally I had previously taught people in interviews to give 2 to 3 minute answers to questions, but that's in the old style format where you're getting a bit of back and forth from your interviewers. But actually in this format, you've got to be prepared for that. God, I've been talking for ages. Are they bored of me? How do I keep my energy up while I'm talking for 5 minutes? You've got to sound like you're still engaged in the question and remember what's happening as well.
Yeah. How did it feel for you, Tash? How do you think you did? How did it?
It gave me the sweats. I was like, this is giving me the heaves of remembering what it was like to do this. I think, to be honest, there were probably bits of it that could have been cut. I think it could still be streamlined. A lot of this was written in a bit of a rush between feeding my baby today. So it's definitely not like the finished product. And I think that's part of why you do the practice that Rachel was saying, that you do it again and again and again. And it's not about writing out a script that you read from. It's about having those points that you want to make in your head, but refining how you're going to say them. So yeah, I mean, it's definitely not, to me, what I would consider a finished product, but I think it got across how much I love the job that I do. I would hope that would be the main thing that the interviewers took away from it, and that they know that I've seen a few things and done a few things that are relevant to the career.
And I think you really did, and I think you extended a bit. So I think you extended into the death of a baby. And I think sometimes that's a little bit of a brave thing to do, but I think it's a really good thing to do. You gave a bit of yourself there. It's quite a difficult thing to talk about. And it is so much part of being a neonatologist, in the absence of continued life, is giving a good death, is assisting a good death, is so, so important. And you have to feel fulfilled by that. That has to be a fulfillment to say, okay, this is a life we couldn't save, but I feel like we did the best possible thing for this family. And that really came across, and that really showed a maturity, I think, that was really nice and really, really helped me understand that you knew what this job is. It's not just running, it's not just going to exciting deliveries and putting tubes in orifices, or as Canel says, making an orifice if there isn't one. I really I really got a sense of who you are and your kind of value system that you bring to it. So that was really nice. Chloe, and you got your hand up.
Hi, yeah, sorry, I have to I'm starting to be a bit remote now, so sorry, but I really liked how you started it by sort of earmarking what you were going to talk about, because it sort of engaged you into the answer, and then throughout your answer it was sort of, you could pick up those highlighted points, if you get me. So I thought that was a really good sort of like introduction to that answer. Yeah,
I quite like that the threads idea. I think, like, if you wanted to write down what are the qualities of a good neonatologist, you could write a list as long as your arm, right? But you don't have the time to talk about that. So I think what I tend to do is to pick up 3 things per answer that I think are the most important, and how I'm going to convey that, and that I can prove I have some experience in those areas. And I like that structure of an answer. Not everyone, you don't have to use that structure, but I quite like headlining, these are the 3 points I'm going to make to answer your question, and then I'm going to tell you those 3 points, and then I'm going to summarize, hopefully, those 3 points again, basically.
Absolutely true. And it doesn't matter what interview you're in. Consultant interviews, you'll be doing the same thing, learning the same thing, and that's exactly it. Pick 3 things that you want to tell people, tell them what you're going to tell them what you told them, finish, and stop. So it's clear that you've stopped and you're done. Because if you summarize, I know that you're done, I know I can move on, or I can prompt you to add more. and it sort of avoids that kind of like, is she done? Is she not done? If you can. I think we should move on to the next question because I'm in the interest of time. Rachel's agreed to do 2. So we're going to Rachel.
I think I was strong-armed into 2.
So, Rachel, thank you for coming today. Here's your question. The delivery suite at your DGH has contacted you about a 27-week gestation mum who they expect to deliver very soon. She's received 1 dose of steroids and there is concerns of a concealed abruption. Can you tell us the key things that need to be considered in planning and going on to manage this delivery?
Okay, so this is a 27-weeker in a district general hospital with 1 set of steroids on board who may have a concealed abruption. Okay, so I've been in very similar situations in various district generals and tertiary neonatal units. So I would approach my preparation to this from 2 perspectives. I would look at it from a management and leadership perspective and from a clinical perspective. So from a management perspective, the first thing I would do is go and seek information. So I would speak to the obstetrician, the midwife, check on the size of the baby, the antenatal scans, any sepsis risk factors, if they'd had mag-sulf, any other relevant information that I needed to know prior to this delivery, and how high their concerns were about the abruption. I would then assemble my team. So if my consultant wasn't there, I would call them in urgently. And I would make sure I had a senior nurse and an SHO. And if there was another registrar available, I would call for them as well, if possible. Then I would brief the team that I had and I would allocate roles, including who would be the team leader and who was going to document, because it's possible this could be an extensive resuscitation requiring careful documentation. I also would then communicate with the obstetric team because their involvement in our teamwork is really important. So I would talk about optimum cord clamping if that's possible, and doing that with supported transition. So doing PEEP during optimum cord clamping if we're able to, depending on whether or not we're in theatre or in a delivery room. This is probably going to be in theatre. We would prepare and communicate accordingly. I would also talk about how the baby needs to go into a bag for thermoregulation purposes. Then I would let the nurse in charge on the unit know what was happening so that they can set up a space, and also to check that there's no other urgent issues going on, because I know I'm going to be away for a long time and I'm likely to be the only registrar around, and see if we need any extra help for the unit. Then I would ask the nurse in charge if they, because I know a sick baby potentially is coming, can let a tertiary unit or transport team, depending where I am, know that there is an impending delivery of a baby that is high risk who may well need uplift. And I'm not asking them to come, I'm just asking them to be aware that this may be a problem shortly. Then I would assemble and prepare all my equipment. So I would have all the standard equipment for a preterm resuscitation, but the most important things to focus on would be getting the room or theatre as warm as possible, having a bag or a neo hoodie for the baby, having the right resuscitaire settings, which often people forget, getting a long PEEP circuit if we're going to do supported transition, especially at a section, and make sure we've got surfactant because this baby's likely to have respiratory distress. Then I would go and find the parents, and depending on how imminently they were delivering, I would introduce myself, I'd explain my role, I'd introduce the team, and I'd find out what they know, and I'd give them a little bit of information, but basically say, we'll keep them updated as we go along. Now moving on to a clinical perspective. So the 3 main things I'm going to worry about is that this is a very preterm baby. So they are likely to get cold, they're likely to have respiratory insufficiency, and we may have a problem with hypovolemia if there has been an abruption. So from a thermoregulation perspective, we're going to go straight into the neo hoodie or bag. We're going to have the hot room, the hot resuscitaire. We're going to do continuous temperature monitoring if we can. If that's not available, we will allocate someone to do temperature in the axilla every 5 minutes. We would also try to do optimum cord clamping in the bag if possible. Respiratory wise, I'm expecting this baby may well require some resuscitation with inflation and ventilation breaths, but they're definitely going to need some PEEP. I'd be very surprised if they didn't. They may require surfactant, which might be via LISA or Ensure, and they may well need intubation or ventilation, so I'd be prepared for all these eventualities. And then the final possibility is there may have been an abruption. So the baby could well need emergency blood, which would require a UVC. So I would want that kit ready, and I would want to know where the emergency blood was. So I would approach this potentially very sick baby from a clinical perspective and from a management perspective, thinking about escalation of care and preparing for all the eventualities with appropriate consultant support.
Thank you, Rachel. 4 minutes, 26 seconds. I feel like this is getting a bit competitive now.
It's a bit quick, talk too fast.
No, I just feel like, it's who's going to get nearest to 5 minutes. Fantastic. Okay, what did everybody think? How did it feel for you, Rachel, first?
Yeah, it's fine because it's what I actually do now. I think we talked about this when we were preparing for it, didn't we? It feels easier talking about it now because I routinely do it. And I was just thinking, what do I actually do? And that is what I actually do. Yeah, it's okay. I had to leave some things out on purpose, which was quite hard. So I was like, but yeah, it was good. It was all right.
Weirdly, this happened to me this morning at 6 a.m. It really did. It was a 24-weeker with an abruption. So yeah, a difficult airway it turned out. But anyway, there you go. This is common, really, really common. Okay, what do you, I think, what was really good is I really had a sense that you do that. You talk like it is what you do. And I didn't get, I didn't doubt that actually from what you said. I didn't think you'd learnt it. I think it is what you do, or you would do. What do you think was missing from Rachel's answer? What do you think you'd have done differently? She still had another minute and a half. If I'd have said to her, you've got another minute or so, what would you like to add? What do you guys think would have been she could have added to that answer? And then I'll tell you what the positive and negative predictors are. Katie, you can just shout.
While no one else was talking, I'll talk. I suppose how do you know where to stop? Like you could keep talking forever, and then we show them to the mum, and then we go down to the unit, and blah, blah, blah. Until they get home. It's yeah.
Got to think about the question though, because what they said was, how would you prepare for this delivery? And I think the initial management as well, prepare for that. It's not talking about the ongoing care of baby. I wouldn't talk about ventilation settings. I wouldn't talk about antibiotics. I wouldn't, probably for that question, I don't know what Callie thinks, but it seemed to me like the very early prep was what was being asked for. So that's how you know when to stop, I think.
I think that's true. And I think if the question, if for instance, I was worried about that in the question, and I'd said preparing and managing, and I felt like she'd only heard prep and she still had a couple of minutes, I'd have said, is there anything you'd like to add about the management of the baby, which was the second part of the question, just in case she didn't hear it, and just to kind of guide on that. I think that would be reasonable, because we're just telling you the question again, really. Or sometimes you might find they just say, I'm just going to say the second part of the question again for you. And if people say that to you, it means that you could give a bit more and push your mark up. So there's something that you haven't mentioned. I didn't do this for the intro questions with positive and negative indicators as such, but I'll do it for this one. Basically, a structured approach. You've got to think about team and human factors. Tick. General care, essential newborn care of any baby, regardless if they've got congenital diaphragmatic hernia or a TGA, doesn't matter. There's a group of stuff that we do the same for every baby. You do it every day. Talk like you do it every day. Talk about what you do. And then there's the specialised care. So Rachel talked to the specialised care around what preterm babies need and the abruption, which was kind of the crucial thing in this. And it may be anything, maybe preterm with anything, added on to that. And always be family centred. Always talk to the families. Always mention breast milk. She didn't mention breast milk. Honestly, shoehorn breast milk into every question, because you're never criticised for putting it in, and you might be criticised for forgetting it. So just put it in. admittedly, if you're talking about data, you might not want to talk about breast milk. But a lot of these, you just need to show that you are family-centered in the way you approach cuddles and breast milk. What does the family want from this moment of birth, and how can you deliver it? I'd like to take the baby over. Before we take the babies to the neonatal unit, I would aim to take them over, and I tell them that we're going to try and bring our baby to meet you before we whisk them off. Things that are not great if they happen are a disorganized approach that feel a bit scattergun. You need to have a systematic approach to those sorts of deliveries, otherwise you can't be a good neonatologist. So we're looking for a systematic approach, something that, you know, is planned, that shows that you've done this before or you've been there before. Don't forget human factors and team, allocating roles. One thing you didn't mention, may be less relevant for this case, but this might be a NICU case. It might be a meconium aspiration deteriorating ventilator. Do think about the level. Where is this baby going to go? Have you got a cot for this baby? Do you need to move around other babies? Speak to the nurse in charge. Where is this baby going next? Does this baby need ECMO if they're a PPHN? Who do you need to speak to? So we want to see you going to the next step, the capacity step, the referral step. Like, how am I going to get an ambulance? Who am I going to sell this baby to? Can they stay with me? Is it not safe for them to stay to me? How quick do I have to move? That overview is really important, that you can show that. That's the next level, I would say, and we are looking for that. Leah.
Thank you. I just wanted to ask if we are allowed to refer to frameworks. For example, could you say there that you will discuss parental expectations based on the BAP perinatal framework for preterm deliveries, or something like that, that can show that you know that there's stuff out there that you consult every day and that you will use this for parental?
Absolutely, but don't do a James and go down that rabbit hole. We're not going to be able to say to you, well, what if they're 22 plus 1? What if they're 22 plus 0 and have no steroids and 350 grams? Because, you know, we're not going to be able to do that. But some people do tend to go down a rabbit hole themselves, where they start having that whole internal dialogue out loud. So just, yeah, state the guidelines that you use. Stop, move on, because we know you know them now. You don't need to show us that you know the exact content. I'm going to go on to the next question.
Kari, there's one question in the chat also from Pura.
Oh, yeah. Okay.
Saying, what is the scoring criteria? What quantifies a score of 4 to 5 compared to 1 to 3?
Yeah, so it's what you'd expect. So 3 is standard response, 2 is not quite good enough, 1 is not good enough at all. So 3 is you've got to get a 3 to be a sort of a satisfactory. 4 is better than satisfactory, and 5 is outstanding, kind of thing. I'm paraphrasing because I'm probably not allowed to tell you what's exactly on the sheet, but you know, you've got to nudge it into a 3 really. Yeah. And of course, there's always going to be one you're not going to score as well on. Score high on the ones that you can score high on, except that, you know, you're not going to be perfect at everything. Don't let perfection be the enemy of good enough. It's another good life motto, I think. Because we're all perfectionists as neonatologists. James, are you ready? Let me find your question.
Yeah, good enough.
I think ready enough. Okay. You are concerned that your tertiary neonatal unit may be underperforming compared to others in the region. What metrics might you use to measure the quality of your care, and how are you going to fix this problem that you have? They'll word it better than that, sorry. If you've identified a problem in performance, how are you going to go about improving it?
Okay. So I think this question is about 2 parts. The first part is particularly about benchmarking and about what kind of metrics we could use to look at problems and concerns around performance. And then the second part is really about how we could try to effect change and how we could try and improve the performance and address some of the issues that we've identified. So if I start with the first part, so I think obviously the first step in all of this would be to try and gather some more information. I think obviously ideally you would want to get as much information as possible from as many different sources as possible to try and understand what the concerns about the performance are. I think approaching this in just a more sort of general holistic sense, if there were general concerns about the performance of the unit, I think the best place to start would be really to be thinking about three metrics or three types of metric that you could look at quite quickly using existing data sources. And those would be looking at the outcomes that our patients are having, looking at some process measures to see about the quality of the care we're delivering, and then thinking about some measure experience and how the journey that the patients and their families go on. So if I start by talking about outcomes, I mean, I think that the first outcome, and obviously the most important outcome that springs to mind, is patient mortality. And obviously there have been some very high profile cases recently where that has been a real issue in particular units, in particular services. The mortality data could come from various sources. It obviously is collected as part of NNAP data, as part of the Badgernet data that we collect, and used to compare to appropriate units. So at the moment I'm working in a surgical unit, so it might be more appropriate, rather than just benchmarking to the other units in the local area, to consider benchmarking to other surgical units within our network or other surgical units more widely, as they're likely to have a similar case mix. Other outcomes that we could look at are things like diagnoses like bronchopulmonary dysplasia or chronic lung disease, things about sepsis, even rates of necrotizing enterocolitis. They're all standardized measures within the NNAP, and that data we could look at quite quickly using the existing data sources, looking either for changes or looking for differences with other local comparable units. In terms of process measures, again, I would be looking at NNAP data. He'll find it. One moment. So the other process, thinking of process measures, looking at NNAP measures, there are some particular process measures around things like thermal control of babies who are admitted to the unit, looking at rates of uptake of ROP screening, and things around avoiding unnecessary term admission. So we could look at those measures to get an idea of the quality of care we're delivering. And then the last area I talked about was the experience of patients. Most units do sort of have some kind of discharge questionnaire, like the friends and family test, on looking at some parents' satisfaction. I mean, one of the previous trusts that I worked in, I worked to introduce a monthly ongoing parent satisfaction survey, which gave some more rapid feedback on the issues that parents were facing. This was particularly during the COVID pandemic. And we were able to use that to identify particular unit problems. So for example, there were some concerns around whether staff were following particular policies around things like use of mobile phones that were causing some quite sort of significant tensions with parents that hadn't been picked up in other sources. We were able to address those rapidly. So that would be how I would try and look at to benchmark and to understand where our issues with performance might be, thinking particularly around those outcomes, process measures, and the experiential measures. If we then talk a little bit about how we're going to address the issues that I identify, so I would then be thinking about some of the more QI methodology, and be thinking about how particularly we can start to engage all of the necessary stakeholders and use some of the structures that exist. In the past, I found it quite helpful to sort of initially adopt a SWOT framework, so looking at strengths, weaknesses, opportunities, and threats when addressing a problem. So thinking, again, an example from a previous unit I worked in, I was asked to look at updating the difficult airway policy in line with the latest BAPM guidance. But when we did that, we realized that actually, whilst there was sort of an assumption from the neonatal unit that the anaesthetics team who were present would be able to provide support in the case of a difficult airway, when we went and spoke to the anaesthetic team, because there was not any paediatric service on site, they actually said that the obstetric anaesthetists were absolutely not the right people to be talking to. And so that was an example of an unexpected threat to the service that we then had to work to try and address. I think it also reflects how important it is to get all of the stakeholders involved. Again, a difficult airway guideline sounds like something that's quite simple, and a lot of people just think it's having a trolley and keeping it stocked. But it became very clear once we started to speak to the other teams who we thought might be needed or we expected would be needed. So things like the ENT teams, the local services, again, it became much more complicated. And that ranges from complex decisions about things like ENT and who would be the right person to call, but also it comes down to very practical day-to-day issues around things like who are the most appropriate people to make sure that the trolley is stocked. And are, for example, the HCAs happy to check the equipment, or does it need a bit more specialist input and supervision? So what we'd want to try and do is to identify the problem that we've identified, look for the right way to look for the best way to address it, take all the stakeholders on board, and try and address the issues we identified.
Thank you, James. What was the timing on that? You had a lot to cover in that question. 6 minutes. Yeah. I think there is a lot in that. I love the way at the beginning you kind of repeated the question back and recognized there was 2 parts to it. And I didn't have to worry that you were not going to get to the second part, because I think you quite clearly said it back to me. But there is a lot to say in that question. Has anyone got, how does it feel for you, James, first?
It's
Daddy?
just we just one.
So what did others think? Positive indicators from James's answer. Put them in the chat if you don't want to say.
It's been I think a little while, obviously, since I did the grid interviews, and yeah, it's slightly unfamiliar. I think obviously having interruptions always is a challenge, and might happen on the day. I think trying to think about what they're asking and have that framework there, so you're signposting what you're going to say, you're making it clear to everyone, so that even if you then actually forget or you run out of time, at least they know that you were planning to try and get there.
Yeah, I really liked how you put examples in as well. So I really got a feel that you have been involved in this stuff. I think this question requires 2 things. It gives you opportunity to talk about what you've done in quality improvement, so model and answer around that, but also your knowledge of benchmarking metrics, NNRD, attain, embrace. Just know about that stuff and don't be frightened to name drop it. I've already told you I can't say, tell me a bit more about embrace, Jess. I'm not going to do that. So you don't need to worry that I'm going to pick out something and then really interrogate you on that one thing, because that's not how this interview works. So do mention those important things, because it shows that you're aware and you've got awareness of what's happening in the specialty. Leah.
I just want to ask, if you get over time, will you just be cut off?
If you get to stop you losing time on the other questions because you can't go over the 25 minutes, we will usually say, I'm just going to stop you there, or we might say, I think if you could just wrap up and we'll move on to the next question. We would usually not let you hang yourself by going on for 15 minutes and wreck the rest of your interview. I think that would be an unfair thing to do. So we agreed at the beginning of the day that we would sort of say, your time's nearly up. Do you want to bring it to a close? And we'll move on to the next question. So yeah, I would have a timer in front of you so you've got a rough idea. And I think it was fine to take 6 minutes for this question, because I think the first question you might have used 4, and that's fine, Ray says, very easy to follow, organized. Yeah, be systematic, because it keeps the panel engaged in what you're saying and following it. I've written for positive indicators on my know your metrics, know what they are. I love the way it was broken down into kind of mortality, process, experience. That was really nice. Know what quality improvements you've done and what you did and how it actually changed, and refer to it. Understand what benchmarking is, so so for instance, we've just transitioned to Epic 2 or 3 years ago, and it doesn't talk very well to the NNRD, and we are not benchmarking well at all against anyone else. That doesn't mean our ROP screening is not gold standard, because it is, but it's definitely not looking like it from our data. So data is only data in, data, it's only as good as what you put in. It's what you get out. Be aware of data surfaces, sources, risk, capacity, quality, flow. As I say, as a consultant, I'm mostly thinking about flow and capacity, more so thinking about quality and risk, not often thinking about clinical care of babies, I'm afraid to say. We love it when we're attending because we get to do that. That's the best bit. But those are the things that this sort of question is asking you about. Risk, capacity, quality, flow. Those are the things I think that you need to be thinking about. Oh, last question. We're running over and I'm really sorry. Do you want to do the last one? Should we make it a quick one and make her only talk for 3 minutes?
If they want to hear it, I'll do it. I can talk fast. It's all right.
Excellent. Okay, Rachel, this is your last question. It's nearly over, is the subtext. At the end of your shift, the nurse looking after a baby under your care realizes she's given the baby the wrong dose of gentamicin. The baby's reported to be well. What immediate steps are you going to take to manage this situation? And how could you help ensure that similar incidents do not happen again?
Okay, so a baby's been given the wrong dose of gentamicin. What are the immediate steps I'm going to take, and how will I reduce the risk of this happening again in the future?
Yep.
Okay, so I've been told that the baby's well. So this gives me some time to seek information. This is unlikely to be an acute medical emergency, although it does require attention. So the first thing I would do is speak to the nurse in question and find out what happened. Was it too much gent? Was it too little gent? Was it given at the wrong time? What's the history of the baby? When did they last have gent? What's the renal function? Relevant questions like that. I would try and ask about how it happened. Was it a prescribing error? Was it a calculation error? Was it a checking error? Where has it gone wrong in that seeking information process? The next thing I would do would be, although I'm familiar with the management of if it was an overdose of gentamicin, familiar with it, I would still check on ToxBase to see if there was any additional information that I could glean from that. Then I would go and see the baby. If the parents were there, I would speak to them at that time, and if they were not there, I would call them. So I would examine the baby. I'm unlikely to find anything from a clinical perspective, but it's good practice to do so. I would speak to the parents. I would introduce myself. I would tell them what had happened, and I would say the baby's been given the incorrect dose of gentamicin, and if I knew if it was too much or too little at that point, I would give them that information. I would apologise, which would be very important. Then I would explain to them about the ongoing management. So were it an underdose, this is less important, and we can top up the dose and manage the baby henceforth. If it was an overdose, then additional investigations will be required. So the baby will need to have a series of blood tests to look at renal function and the gentamicin levels, and the baby's hearing will need testing in the future. I would again apologise. I would ask if they had any questions, and if there was any concern from them about making a complaint, which is entirely possible were it an overdose, then I would direct them to the PALS, Patient Advice and Liaison Service. I would then go back to the baby and initiate the management required in that situation. I would then tell my consultant what had happened, and I would document everything very thoroughly, including the conversation that I had had with the parents. Then I would do the steps that we need to take to reduce this incident from happening again, which is the second part of the question. So the first thing would be to do an incident form by whatever system is available in the hospital, and that feeds into the risk assessment and risk management process and the governance process around that in the unit, which will go through the consultant responsible for risk. That may reach the threshold for doing a root cause analysis. I've done root cause analyses in the past for serious incidents, which involve looking at timelines of events. This might not meet that threshold, but they would still look, for example, at the fishbone driver diagram to see if what the contributing factors to the event were, if it's a process problem or if it was an individual training problem or a situational issue, for example, understaffing. We would also do a driver diagram to look at the steps in the process of administering gentamicin. And then the outcome of that process might identify some areas for improvement, which could lead to a quality improvement project, for example. So overall, I would make sure that the baby was safe. I would speak and communicate with the parents. I would document accurately, escalate to the consultant, and then take steps to feed into the risk management process.
Thank you, Rachel. 3 minutes, 32 seconds. Felt like longer. Loads of information. But loads of information you got across in 3.5 minutes. Really, how did it feel for you?
Well, I missed out the thing I was going to miss out, and I was wondering, because I had this actual question in my interview, as you know, I was wondering if because it felt okay. If the guys listening could think of something really important that I didn't do, which I did say in my interview and I do in real life, but it's really essential.
Stick it in the chat if you don't want to unmute.
Yeah. Done that kind of, but official duty of candor, yeah, could have said the words. Yeah,
I would say the words.
yeah.
I would.
Did you look at the drug chart?
Seeking information, probably. Could say I'd explicitly not looked at the drug chart. Yeah. Come on, you can get it. It's a big thing. It's a big thing.
You might have to tell us.
So it's the nurse. So it's looking after the other staff. Yes, exactly. Yes, talking to the person that made the mistake. So I found this was a really good opportunity to talk about kind of teamwork and well-being and team support. So check on the nurse, check if they're okay, check what happened, do they need any support, what can you do for them, those kind of things. And I think that's a really essential part of that question, actually. But yeah, should have said the words duty of candor, definitely.
And some of that around being a supportive team member is about the language that you use. And sometimes people inadvertently throw their team under the bus in this question. I've got to say, they don't mean to, but they say something that is maybe slightly patronizing about the nurse, or that when you're looking behind their eyes, you know that what they're actually thinking is, oh, it's the nurse's fault. You cannot go anywhere near them. It's not the nurse's fault, of course. It's really not. But sometimes just language slips you up. I have brainstormed what I think we're looking for in this answer, and I think a more governance-y, multidisciplinary, team-working answer, because this may be a complaining parent, it may be another drug error, it may be a conflict, it may be a colleague in difficulty. I don't know. It may be any of those things that are outside clinical care. And I'm just going to tell you what I wrote down when I had a total brain, like, what's the word I'm looking for? Anyway, I'll come to it. So I'm looking, can you contain? You were innately, the way you told that story was containing. This is an awful thing for some families. It's terrifying for families, and it's terrifying for the nurse sometimes. That child's going to be deaf because of me. That's where people's heads go, and don't ever underestimate that. But you were so contained. I had no doubt that you would have contained all of that really quickly, if that in real life, because you were so contained in the way you gave it, and you talk like you contained that situation. And as a consultant level and senior edge level, that is what you do day in, day out, is about containment. It really is what you do. And that's what we're, so I've got can contain, safe approach, so safety first. That you were methodical in your approach and your answer to it, that you were honest and transparent, and I believed you were being honest and transparent, that you listened. So some of the circumstances that you know, what is the parent worried about? What is the nurse worried about? What are you worried about? It's probably something completely different to what the family's worried about. So listening in any of these scenarios, complaints, colleagues in difficult, any of those things, conflict, you've got to show that you can listen and really listen. And hear other people's perspectives. Push it up, always push it up. Always say I'd speak to a senior. If that's your clinical director, speak to your bloody clinical director. Whoever it is, push it up, and always say you're going to push it up, and think about who should I be telling above me, because this is quite an important thing. Or say, I don't think in this circumstance I would need to discuss it with my consultant because I feel quite comfortable with it, but under other circumstances I definitely would. You need to be really sensitive to the family's needs and show that, because this is kind of terrifying. It's like every time we pull the buzzer on the unit, we all run. A little bit of that mum dies inside. And I know that's really difficult, and I know we have to do it, but yeah, I don't think you'd kind of know that. We're all so used to it. We all just think, oh, you know, fine. But, you know, really understand and think about and be sensitive to the family's needs and concerns. Don't throw your team under the bus, even inadvertently. And it's easy to do. Reassure the nurse that did it, reassure the parents. You were really reassuring in your answer. Be supportive to the family and staff is part of that. Offer to follow up, always take it to the next level. All these questions, take it off the end to what happens next. Even if it's just final sentence, I would then need to go and organise the referral and speak to the referral teams. I would need to, you know, whatever it is, what is it, closing the loop or taking it to that systems. Think health systems, don't think individual, this, that and the other. Don't be task orientated. This is a health systems approach to the answer. Multidisciplinary is not just about training the doctors or training the nurses, but training the whole team to mitigate drug errors and build an environment where they can do their job to the best of their ability, creating a safe space for them to do that. So always think about the whole team, because that's what these questions are about. Clarify the facts before you put your foot in your mouth. Clarify that this baby has actually been given an overdose of gentamicin or an underdose. Clarify in your head what that really means. I'm not worried about it, or I am really worried about it, and I do think we have to go and do it X, Y, and Z now. Notify people, explore the situation with others, and reflect. I've written in capital letters and underlined twice. Reflect on the situation, reflect on your role in it and what you did. And if you can show that you've had a similar circumstance where you reflected and changed what you did next time, share it. I think that's it. Hand it over to somebody else. That's the closing thing again. Sometimes the closing thing is handing it on to someone else. Sometimes it's just communicating it. I'd write an email and make sure so-and-so and so-and-so was aware, whatever it is. That was my brainstorm. I think this is quite a tricky one because there's quite a lot to get in there, but I think it's okay as long as you're systematic in your approach and you're quite systems and multidisciplinary in your response, you'll be fine.
It feels like the one where there's most like tick box things to squeeze in. Like you would do all of the things, but like, have you said that you have spoken to the consultant? Have you said that you have done the duty of candor specifically? You know, like whereas the others, it feels more. I think
that's true, and I think it's also the one that can be just really come across as like really by rote, like you've just learnt it. You don't do it. So I think it is the one that you've got to really make sure the difference between a 4 and a 5 or a 3 and a 4 even is not, do you know what to do? Do I believe that you do that? That's the thing. And when you practice when you do your mocks, do that. Say, did you believe me, or did you just thought I read it in a book? What was it about what I said? What can I add to make you really believe that I did it? And it's basically giving examples of times that you've done it, I think.
Yeah, I was going to ask with regards to examples. So in a question where they're giving you a specific scenario, obviously your time is slightly taken up by addressing that scenario they're giving you, but are you okay to kind of throw in a few examples taken from your own practice just to show that you haven't just kind of learnt it and written it down and remembered it and regurgitated it, that you have been there and done it many times?
I think so. I think that's really what we want. You've been there, you've done it many times, and that's exactly it. And that's why those of you who are going in a year, go to the capacity meetings, get involved in the root cause analysis, you know, do all those things so that you've got those experiences to relate to.
I think the examples are really good. I would say make sure you answer the question though. Don't just go off on your example. Yeah, so I would be very clear that you've ticked all the boxes that you've done, that you've ticked it, and then you can extrapolate into and I would do one example, because you're going to run out of time and you're going to get distracted. And however lovely your example is, if you haven't hit the marks on the other stuff, you're scuppered.
So I think we've run 15 minutes over, and I'm really sorry for that, but I hope it's been really, really useful. To summarize, practice. Prep is all about, you can prep for interviews. Some people do have better innate interview skills than others, but actually everybody can give a good interview, and it is about the time you put in, and it's about the practice. So go away, find somebody to do a mock with you, find loads of people, talk to yourself in a mirror. When I did my consultant interviews, I was in Uganda, flying back the night of the interview and going straight off the flight, putting a suit on and going to the interview for my first consultant interview at UCLH. And I just sat in front of a mirror, talked to myself for 3 days in Uganda, because that was what I had. So you know, I think it's fine to do that. Record yourself if you can bear to listen to yourself back. You know, you're closer and closer to the YouTube generation of my children, Gen Z, who used to talking to yourselves on film and voice memos all the time. So I hope you can do that. If you really struggle, we have agreed that we couldn't offer mock interviews for everybody here, and I probably shouldn't be mock interviewing people because I may well be on your panel. But if you really struggle, please get in touch with either Ray or Ellie, and we will try and connect you with people. But actually, I don't think they need to be neonatologists. Tell them the structure though. Tell them this is what I've got to talk for 5 minutes, and there's not this to and froing, so that you get to practice the way the questions are done. But practice is key. But like, drop us a line if you need any support, and we will happily connect you with some level 3 consultants to grill you. And there is Eva's email address. Thank you, Eva. Thank you so much to the panel. Firstly, thank you to Ray actually for organising, and Eva and Ellie for the whole webinar series that they've really supported putting together. Thank you to the panel for being so brilliant, because it's so important to hear from you, and you've given really great examples today, and I hope all of you feel empowered and inspired that you can do that, because as Rachel said earlier on, you can do this, you've just got to prep. You can all do this, you've just got to prep. And it's obvious in an interview, it's absolutely obvious on the panel who's prepped and who hasn't. That's what I can tell you. And they are the people that score highest. I can tell who's done 22 mock interviews and knew what to expect. And now you all know you're going to be great. Good luck. I will see you in interview or on the other panel. I will probably ask to be on the other panel or flip you if that happens. I'm rooting for you. I'm rooting for more London trainees, because we need you, and we're looking forward to working with you. So good luck, everybody.
Good luck, everyone.